The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar, Achieving Hemostasis in Women with Bleeding Disorders, Challenges and Therapies in VWD. My name is Carrie Funkhauser, and I am Director of Education for the Foundation for Women and Girls with Blood Disorders, and I will be moderating today's webinar. Next slide, please. The Foundation for Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally treated and managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Next slide, please. Today, our presenters are Dr. Andra James, Consulting Professor of Obstetrics and Gynecology at Duke University Medical Center. She will be joined by Dr. Margaret Ragni, Professor of Medicine and Clinical Translational Science at the University of Pittsburgh Medical Center. She is also the Director of the Hemophilia Center of Western Pennsylvania. Next slide, please. The Activity Medical Director for today's webinar is Dr. Andra James. The planning committee for today's presentation include Dr. Barbara Conkle from the University of Washington, Dr. Roshni Kulkarni from Michigan State University, Dr. Kenneth Mann, formerly Emeritus Professor at the University of Vermont, James Munn from the University of Michigan, Dr. Jennifer Dietrich from Baylor College of Medicine in Houston, and Dr. Evelyn Lockhart from the University of New Mexico School of Medicine. Next slide, please. In accordance with Creighton University Health Sciences Continuing Education Policy, the Faculty and Planning Committee for today's webinar have disclosed any significant financial interests or other relationships of interest relative to the topics that will be discussed during this program. Such disclosures allow you to better evaluate the objectivity of the information presented in this webinar. Next slide, please. To ensure the best sound quality during this webinar, all attendees will be muted. However, all attendees will have the opportunity to participate in a question and answer session with the instructors at the end of the webinar. You can submit your questions during or after the webinar via the chat box in your GoToWebinar control panel on the right-hand side of your screen. We will address them during the Q&A session at the end of today's presentation. Next slide, please. This learning activity is offered through Creighton University Health Sciences Continuing Education Program, which has been accredited for offering 1.0 AMA PRA Category 1 credit for physicians and 1.0 contact hour for nursing professionals. Next slide, please. Before we begin the webinar, we would like to quickly poll our audience to see how many people are watching the webinar with you today. We recognize that several may be watching in one location as a team. Therefore, please take a moment to input your response to our poll using your keyboard. Thank you. Next slide, please. The following are the learning objectives for today's webinar. For those who wish to refer to these later, we will record and archive this webinar on our website, fwgbd.org. I would now like to introduce our first speaker, Dr. Andra James. Next slide, please. Dr. James?
Thank you. Can I just confirm with our team that you can hear me?
Yes.
Great. So why women and girls? Why do we speak specifically about women and girls? Well, women and girls are rarely affected by severe hemophilia, but they are equally likely to have other bleeding disorders, including von Willebrand disease. But when they do, they are disproportionately affected due to the bleeding challenges of menstruation, miscarriage, childbirth. So it turns out 2/3 of persons diagnosed and are treated for bleeding disorders other than hemophilia are female. Next slide. So we have some data from the Centers for Disease Control, female uniform data collection registry on 319 women. So we have some idea about what kinds of bleeding disorders women present with. And in that database, almost 90% of the women had von Willebrand disease. 60% or more had type 1. A small percentage had factor VIII deficiency, platelet disorders, or other bleeding disorders. Now, if you're adding that up in your head, you'll see that it comes to more than 100%, and that's because approximately 20% had 2 or more hemostatic defects. Next slide. So among women, the most common bleeding symptom that women with bleeding disorders experience is heavy menstrual bleeding. From a variety of series of women with von Willebrand disease, we know that anywhere between 32 and 100% experience heavy menstrual bleeding, and in the better quality studies, that's bigger studies, that's about 80 to 90% of women with von Willebrand disease also experience heavy menstrual bleeding. Next slide. We also know that women with von Willebrand disease, from a study that was conducted under the auspices of the Centers for Disease Control, experience other reproductive tract bleeding besides von Willebrand, besides heavy menstrual bleeding, otherwise referred to as menorrhagia. And this other reproductive tract bleeding includes ovarian cysts, women with von Willebrand disease, and presumably other underlying bleeding disorders are also more likely to manifest endometriosis, fibroids, endometrial hyperplasia, polyps, and require hysterectomy, because these are conditions that are manifest and complicated by bleeding. Next slide. So why is it that women have these bleeding challenges? Well, during the menstrual cycle, the lining of the uterus builds up under the influence of estrogen from the ovarian follicle, which you can see in the top line in this cartoon. And there is a portion of the lining of the uterus, as you'll see in the bottom slide, that we talk about as the basal layer, which exists continuously, but under the influence of estrogen, the functional layer builds up and develops, becomes thicker, and you can see the little spiral arteries there developing. Then when ovulation takes place, you can see the follicle releasing an egg in the top of the cartoon. The residual part of the follicle starts secreting progesterone. This matures the lining of the uterus, and the lining is shed in an organized way, which we call menstruation. Well, one of the problems is in women at the extremes of reproductive age, or who have other hormonal defects, they can go long periods without ovulating. The lining can continue to build up and break off. When ovulation finally does take place, there can be a very thick lining that is ultimately shed. So even in the absence of a bleeding disorder, women at the extremes of reproductive age during adolescence, where they may not be ovulating regularly, and in the perimenopause, again, where they are not ovulating regularly, the women may have heavy menstrual periods due to an excessive amount of lining of the uterus building up. Next slide. So that is an important point to make in understanding the causes of heavy menstrual bleeding. So causes of heavy menstrual bleeding include local or anatomic reasons as well as systemic reasons. On the left, you see a uterus that is filled with uterine fibroids, but that could be endometrial hyperplasia or polyps. And you can imagine with a uterus that has those anatomic defects that the amount of menstrual bleeding indeed might be very heavy. But also, there are systemic reasons why a woman may experience heavy menstrual bleeding. Next slide. So the International Federation of Gynecologists and Obstetricians has come up with a list of causes of heavy menstrual bleeding, and they include those anatomic aspects, which are polyps, adenomyosis, which is the growth of uterine glands into the uterine muscle, fibroids, malignancy, and hyperplasia, which is overgrowth of the lining of the uterus as well as malignancy, coagulation disorders, ovulatory dysfunction, which we talked about in the previous slides, endometrial, meaning abnormalities of the lining of the uterus per se, which may be due to inflammation or infection, iatrogenic, which is most often hormonal misadventures and not yet classified. Next slide. Our treatment of heavy menstrual bleeding, whether it's in a woman with or without a bleeding disorder, depends on the patient's preferences. So would she like to preserve fertility? If the answer is yes, then the next question is, does she want to become pregnant now? And if the answer is yes, and she has an underlying bleeding disorder and has difficulty in having her menstrual bleeding being controlled without hormones, then certainly she needs the help of an expert in hemostasis. If she does not wish to preserve fertility, then she has the option of hormonal measures, which are the first line in the treatment of heavy menstrual bleeding. And if she doesn't ever want to become pregnant, she has the option of permanent methods to ameliorate her heavy menstrual bleeding, which include hysterectomy or endometrial ablation. And endometrial ablation is destruction of the lining of the uterus. Next slide. So what do we know about what is actually used among women with bleeding disorders? Here are the methods that were used to treat heavy menstrual bleeding in that same Centers for Disease Control female UDC database. And you can see that over half used combined hormonal oral contraceptives to manage heavy menstrual bleeding. Other gynecologic methods that were used are highlighted there in the gold color and include endometrial ablation, which is surgical destruction of the lining of the uterus, the levonorgestrel intrauterine device, which is impregnated with progestin and reduces the amount of growth of the lining of the uterus without systemic effects, and uterine artery embolization, which is used when the heavy menstrual bleeding is due to fibroids. The other methods there in gray, including desmopressin, antifibrinolytics, usually tranexamic acid, blood or plasma products, and platelet transfusions, are the hemostatic tools that Dr. Ragni will talk about later. Next slide. We're going to switch gears and talk about pregnancy and childbirth. Next slide. One of the advantages that women have during pregnancy whether they have an underlying bleeding disorder or not, is that their coagulation changes to help protect them against the bleeding challenges during pregnancy. So I think that my little ovals migrated there, but what I wanted you to see is that factor 8 increases, von Willebrand factor increases, and factor 9 does not increase during pregnancy. So that has implications for our hemophilia carriers and our patients with von Willebrand disease. Next slide. So in this slide that comes from Dr. Jill Johnson's laboratory at the University of Washington, you can see what the changes are in von Willebrand factor and factor 8. And these are women without von Willebrand disease during pregnancy. And you can see there in the red held, the von Willebrand factor protein increases, and you can see in the green held factor 8 increases during pregnancy. So half of women with von Willebrand disease actually require no treatment during pregnancy because their levels, while not entering the same range that women who don't have the disease do, at least approximate the normal range. The next slide. This slide illustrates some work that we did with Dr. Ragni and other collaborators looking at von Willebrand factor levels in women with von Willebrand disease, women who required treatment, as well as women who didn't require treatment. And in the gold, you see women who have no von Willebrand disease. So you can see how around the time of delivery, women who have no von Willebrand disease have quite a rise in their von Willebrand factor activity. That's in the first slide, in the antigen or in the protein in the second slide, and in factor 8 in the third screen there. Women in blue, the women in blue are women who had von Willebrand disease but did not require treatment for their condition. And you can see that their levels parallel the women who are unaffected. There on the left, their ristocetin cofactor levels or activity levels parallel the women who were not, who did not have von Willebrand disease. In the second panel, you can see the actual protein levels, how they parallel those of women who do not have von Willebrand disease. And in the third panel, you can see the factor 8 levels. The group in red is the women whose levels were less than 50% of normal as they approached delivery and were thought to need treatment. But you can see that even though they were treated there in panel 1, that their von Willebrand factor activity levels did not achieve levels close to those of women who were unaffected. They were consistently lower, except right around the time of delivery. In fact, the levels approximated normal, but they are quickly less than normal. Next slide. We're often asked about what is the risk of miscarriage for women with bleeding disorders. Well, we might learn more from bigger studies, but with the data we have now, there's no apparent increased risk with factor 8 or factor 9 deficiency. In other words, people who are women who are hemophilia carriers aren't at increased risk of miscarriage. And there's no apparent increased risk of miscarriage with von Willebrand disease, at least based on the data we have now. And there's no apparent increased risk with other bleeding disorders, except women with fibrinogen deficiency and factor 13 deficiency, who do have a remarkable increased risk of miscarriage. Next slide. So what about bleeding at the time of childbirth, and how are we needing to be prepared for that? Well, it is most often obstetrical bleeding rather than bleeding that is definitively attributable to the underlying bleeding disorder. And when I say obstetrical, I mean bleeding due to failure of the uterus to contract or due to retained products of conception or placenta that prevent the uterus from contracting, and that the most important mechanism for controlling bleeding at the time of childbirth is uterine contraction. And it's less often due to surgical bleeding, meaning due to incisions or lacerations at the time of childbirth, either cesarean delivery, episiotomy, or lacerations. But it is sometimes due to a bleeding disorder, and that can develop acutely due to one of the above problems, and it is occasionally due to a pre-existing bleeding disorder, or a pre-existing bleeding disorder is a contributing factor. So next slide. Large studies of women with von Willebrand disease show that about a 50% increased risk of postpartum hemorrhage, 6% versus 4% in women who have von Willebrand disease. And overall, blood loss at the time of delivery is increased about 50% in those women whose levels of von Willebrand factor or factor VIII are less than 50% of normal. Our research showed blood losses of 600 milliliters versus 400 milliliters at delivery. But since all women are at risk of postpartum hemorrhage, whether they have an underlying bleeding disorder or not, all the usual obstetric precautions should be used if necessary, including Pitocin or oxytocin and other uterine stimulants, and tranexamic acid, an antifibrinolytic agent that Dr. Ragni will talk more about. So next slide. In terms of prevention and management of postpartum bleeding, our hemophilia carriers and women with von Willebrand disease should receive factor replacement. And Dr. Ragni will talk more about that. As far as protecting the unborn baby, obstetricians caring for women who are carriers of hemophilia should discuss the maternal and fetal risks of a vaginal delivery versus planned cesarean delivery, and the option of a planned cesarean delivery should be recommended when an affected or potentially affected infant is anticipated, or I should say severely anticipated that the infant will be severely affected. In those women who elect vaginal delivery, forceps and vacuum extraction, interventions that triple the risk of intracranial hemorrhage in affected infants should be avoided, as should fetal scalp electrodes during labor. And with that, I would like to conclude this section on the obstetrical and gynecologic issues around achieving hemostasis in women with bleeding disorders, and turn the program over to Maggie Ragni, my colleague, Dr. Ragni.
Thank you, Dr. James, and thank you to the organizers with you, Dr. James, who invited me to talk today. It is truly an honor. The work you have done is just simply outstanding, and it's a tribute to what can be done with many unanswered questions in this area. So if I could have the next slide. And the next. So what I'd like to do, this is just a brief overview. I would like to talk about hemostatic management in two situations, of heavy menstrual bleeding in von Willebrand disease and in delivery. And we're going to talk about the burden of disease, the challenges of current therapy, and the potential of novel approaches. So could I have the next slide, please? First, we're going to start with heavy menstrual bleeding. Next slide. So just by way of background, I think most people on this call are well aware that von Willebrand disease is caused by deficient or defective von Willebrand factor, which is located on chromosome 12. It affects males and females, as you heard. There are 3 types, mild, moderate, and severe, and we're talking primarily mucosal bleeding, which is what menorrhagia is. The disease is characterized by low von Willebrand activity, known as ricin cofactor, antigen and factor VIII clotting activity, and of course there are quantitative defects in the multimers for type 1 and 3, and qualitative defects in type 2. Next slide. So by way of this slide, I'd just like to mention that while we understand well the cause, it's the function of the von Willebrand protein that's so critical in hemostasis. It facilitates binding to platelets through GP1B, factor VIII stabilization, as well as collagen binding, so it plays a very major role in platelet plug formation, which we call primary hemostasis. So clinically, when one is deficient or defective in von Willebrand factor, mucosal bleeding results, and among women with von Willebrand disease, the #1 symptom is menorrhagia, now termed heavy menstrual bleeding. Next slide. Could you advance the slides, please? So heavy menstrual bleeding, I'm sorry, is defined as over 80 cc's per month. Okay. The scope of the problem, the burden of the problem of menorrhagia, it's associated with iron deficiency, which is associated with clinical, psychological, and mental cognitive issues, poor quality of life, and current therapy is truly limited by both intolerance and toxicity. So the #1 unmet need in women with heavy menstrual bleeding is the lack of safe and effective therapies. Next slide, please. So when we talk about menorrhagia, it has clearly been defined quantitatively by Higham et al. In 1990, showing that over 80 cc's of blood loss per month was associated with significant bleeding. We call that a pictorial blood assessment chart you're looking at to the right, which when the score is 100 is the equivalent of this 80 cc blood loss. It has high sensitivity and specificity, and it has been validated as a measure of heavy menstrual bleeding. Next slide. So what are the limitations of current therapies? We know that with tranexamic acid, which inhibits fibrinolysis, it causes nausea in as many as 50%. Desmopressin, which releases von Willebrand factor from the vascular endothelium, has been associated with allergic reactions and hyponatremia. Hormonal contraceptives have been associated work by increasing von Willebrand factor synthesis, but may be ineffective or intolerant in 20 to 30%. Interleukin 11, which increases von Willebrand factor VWF mRNA, which has recently been discontinued from manufacture, has been associated with mild fluid retention and, as I mentioned, no longer marketed. Plasma-derived von Willebrand factor replaces missing von Willebrand factor. It's invasive and costly. Next slide, please. What is the current recommendation? I have it highlighted for you in the adolescent or adult woman according to the USHD 2009 guidelines who do not desire pregnancy but desire future childbearing. The first choice of therapy is combined oral contraceptives. Further down, if a woman otherwise is a suitable candidate for an intrauterine device, the second choice should be the levonorgestrel intrauterine system, grade B, level 2B. For the woman who desires pregnancy, Ddavp, antifibrinolytics, or von Willebrand concentrate may be tried to control menorrhagia, grade C, level 4. Next slide. So we undertook a survey of hemophilia treatment centers, of which 20 hemophilia treatment centers responded, who had seen women between the ages of 18 to 45, through these 18 HTCs of 1,320 patients, of whom 61% had heavy menstrual bleeding. In the first-line therapy in 70% of those centers was combined oral contraceptives. The second-line therapy used in 30% was tranexamic acid, and the third line used in 20% was Ddavp or Stim8. Von Willebrand factor was used primarily only when the above treatments failed in only 20%. And when it was used, those who responded indicated they used it at a dose of approximately 50 units per kilogram for approximately 5 days. Next slide. So one of the questions is, what von Willebrand dose would be really important in heavy menstrual bleeding? So we reviewed the literature. As you can see, there are 6 studies here. In those studies, which were not set up to study menstrual bleeding, but rather use of von Willebrand factor, the first 5 studies were evaluating plasma-derived VWF-PB, and only the last was the study, the phase 3 study of recombinant von Willebrand factor published by Gill et al., in which we participated. And what you can see is there's a range of doses of von Willebrand factor that was used in heavy menstrual bleeding with a median of 43 units per kilogram. The range of duration was between 1 and 6 days, but as you can see, it was much shorter in those who used recombinant von Willebrand factor with using it 1 to 2 days only. It reduced bleeding between 95 and 100% with plasma or recombinant, and the adverse events were really not noted. I will tell you there were allergic reactions reporting with the drugs themselves, but not in the context of using them once a month for a menstrual period. Next slide. So one of the questions that comes up when one is using these drugs, and this is a very busy slide, but if you would just go down to the last 3 lines, you would see that while the concern about thrombosis with using a von Willebrand factor concentrate is present, the risk is quite low. In our review in 2015, we found that it was 0.6% for plasma-derived and 0% thus far for recombinant von Willebrand factor. And I would mention that the 2 cases in the plasma-derived von Willebrand factor included one woman who had a venous thrombophlebitis at the site at which it was administered, and one was a man who had a remote thrombosis following orthopedic surgery. Neither were attributed specifically to the drug. So the overall rate was 0.4%, and on the next slide, this was quite comparable to a large ongoing follow-up study, by the way, by Henry Mead with CSL Behring, who have found it to be approximately 0.1%. So it does leave unanswered the question, what would be the role of recombinant von Willebrand factor? And I would just show you here, this is taken from a very, very good paper by Turasek in the Seminars in Thrombosis and Hemostasis. It really shows what the difference between recombinant von Willebrand factor and plasma-derived is. In this panel, in the first panel and last panel, or column, you are looking at the plasma-derived von Willebrand factor, whereas in the middle 4 panels, you are looking at the recombinant von Willebrand factor, and you can immediately see that there are the ultra-large UL-VWF present in the recombinant, but those are missing in the plasma-derived. And the importance of that is it's those high molecular weight multimers that are the business section of von Willebrand factor that are important for binding to platelets through GP1B, for collagen binding, and for factor VIII stabilization. So this recombinant protein is a very high safety, purity, and potency protein. There are no non-VWF proteins, and it has a high specific activity. Next slide. In addition, it has a 1.4-fold increased half-life, suggesting that, in fact, it might be able to be used less frequently than standard plasma-derived von Willebrand factor. We think that it has a longer half-life because this is a fully glycosylated protein. There are more ultra-large von Willebrand factor molecular weight multimers present, and there's no atom TS13. So atom TS13 is the regulatory protein that breaks down von Willebrand factor, which is present in plasma-derived von Willebrand factor, but is not present in recombinant von Willebrand factor, meaning that when you infuse with recombinant von Willebrand factor, you have the most pure potent von Willebrand factor, which as soon as it's infused is then broken down by your own endogenous ADAMTS13, so that there is no increased risk of thrombosis. It's as effective as plasma-derived, as shown in phase 3 trials. It's safe, well tolerated, and there's been no thrombosis or immunogenicity. Next slide. So I believe this is just the summary slide of what I'd already told you. Let's move on to the next slide. So in summary, what I'm saying is that in the unstimulated situation, recombinant von Willebrand factor has higher content of high molecular weight multimers as compared to PD von Willebrand factor. It has higher purity, higher specific activity with no spontaneous aggregation and reduced closure time. At the time of bleeding, which we call shear stress, it has similar functional recombinant resistant cofactor activity, similar functional collagen binding, platelet aggregation, and platelet adhesion. Next slide. So what we're saying is that recombinant von Willebrand factor can prevent and reduce bleeds. It promotes hemostasis in surgery, as shown in the phase 3 trials. It reduces heavy menstrual bleeding. It reduces treatment frequency, and because it contains no factor VIII as a very pure protein of Ddavp only, it has the potential to reduce or to not contribute to cardiovascular risk. It contains no ADAMTS13, so it's very pure, very high potency at the time it is given, but it's non-thrombogenic because once it is infused, it is subject to your own endogenous ADAMTS13 for normal breakdown. And it's safe and well tolerated in adults as well as children. Next slide. So based on that safety profile and potential for improved or pure clotting protein, we hypothesized that recombinant von Willebrand factor, if it were given on day 1 of the menses, would be superior to the current non-hormonal standard, which is tranexamic acid, which is given on days 1 through 5 of menses. We will look at this during 2 consecutive menstrual cycles to evaluate the reduction in heavy menstrual bleeding in women with type 1 or 2 von Willebrand disease. And the schema is shown below. This is a randomized trial in which there is crossover after 2 cycles each. So the randomization is for which drug comes first. Next slide. And as you can see, this is a prospective randomized trial. It will last for 24 weeks. We anticipate enrolling approximately 66 women. We will use a dose of 40 units per kilogram on day 1 based on our findings in our survey of used doses, and tranexamic acid in its standard dosing at 1,300 milligrams day 1 through 5. Our primary endpoint is this pictorial blood assessment chart, which is validated for menorrhagia, and our secondary endpoints are following bleeding severity and cycle length. We will also look at acceptance because this is an intravenous drug, but if it were given 1 day as opposed to 5 days and well tolerated, the question is, would it be an acceptable approach? Next slide. So now we're going to turn to hemostatic management of delivery in von Willebrand patients next. So this has some very interesting problems. We know, based on Dr. James' excellent blood study in hemophilia in 2015, which we had the chance to participate in, that postpartum blood loss is at least 1.4-fold greater than in controls, and postpartum von Willebrand factor levels were approximately 1.4-fold lower than controls. Yet, as we scratched our heads, why would that be? We note that the blood volume in pregnancy increases by 1.4-fold, and could that have any impact on why we see these problems? The standard therapy, as you know, is dosing based on weight at 50 units per kilogram, as I believe Dr. James went through a little earlier. Next slide. So, oh, I'm sorry. Could we go forward? Next slide. Next slide. Thank you. Oh, just go back for 1 second here. I do apologize. Very good. So basically, I just showed you in red that factor replacement at delivery currently is recommended based on MASAC 2017 guidelines only if those levels are below 50 units per kilogram. And of course, if Ddavp is given, one has to monitor sodium and fluid. Next slide. So here, what you can see is what is postpartum blood loss in von Willebrand disease in controls from Dr. James' paper, 437 cc's. In von Willebrand who did not take treatment, it was 448, and in those who received treatment, presumably more severe, were 615 cc's, which is about 1.4-fold higher. And I'd like to point out that this is a pictorial blood assessment chart that Dr. James validated for postpartum blood loss, which is such a helpful tool. Next slide. So the question is, how does von Willebrand factor change in pregnancy? I think Dr. James already showed us this. This is the evidence on which the point is made that there's a 1.4-fold lower von Willebrand factor in women who were treated who have von Willebrand disease. Next slide, please. And just to show you, we had an interesting question from patients from our own center, which we recently published. What predicts blood loss at delivery? And I truthfully had the concept that I would find nothing. What's very interesting is we looked at the 8 patients who had over 500 cc blood loss with the 8 patients who had less than 500 cc's. These were all vaginal deliveries. These were all type 1 von Willebrand patients. And what you notice in red is that the most predictive values were weight, which of course has a lot to do with your blood volume, your family history of bleeding, which just predicts in a greater degree that you might have a bleeding disorder, and risdiplam cofactor, not at the time of delivery, not at the time of pregnancy, but prior to pregnancy, just as we look at for any surgical situation. Well, how severe do you look before that event? So those were all significant, and of course the treatment is confounded by the fact that we were more likely to use von Willebrand factor in someone with significant blood loss. Next slide. So how does volume change in pregnancy? And what this very delightful cartoon shows from Dr. Hitton and Payton, as well as Lou, there's no question that the blood volume increases by about 1.4-fold during delivery. Isn't that fascinating? It's the same difference as the reduction in von Willebrand factor and blood loss in our women. Next slide. So based on that association, we suspect that the von Willebrand factor dosing based on blood volume might be a more appropriate approach. We don't know. That is a hypothesis, that this 1.4-fold higher von Willebrand factor dose would reduce blood loss and improve VWF levels. You know, this is a very difficult question to answer. Dr. James very carefully showed you the many factors that are associated with blood loss at delivery, but we still think it's a compelling question to answer. Can we prevent postpartum hemorrhage using a 1.4-fold higher von Willebrand factor and using a recombinant von Willebrand factor? Let's look at the next slide. So our hypothesis is that intravenous recombinant von Willebrand factor given at 80 units per kilogram, which is about 1.4-fold higher than the current recommended dose that we discussed, would be superior to plasma-derived von Willebrand factor. We would give it on day 1 and day 2 postpartum, as well as pre, and follow women for blood loss using the pictorial blood assessment chart that's been validated for delivery. Next slide. So this is a randomized 4-week trial. It will look at 80 units of recombinant von Willebrand factor versus 50 units per kilogram of plasma-derived von Willebrand factor. We'll look at safety compliance with a primary endpoint of pictorial blood assessment chart. This will require 90 women. Next slide. Our hope is that if you have an interest in participating, we would love to involve you in this most important study. We are in the process of preparing for submission to NIH for this study. Thank you.
Thank you very much, Dr. Ragni, and thank you, Dr. James, both for your excellent presentations. The Foundation is pleased to provide this webinar and continuing education credits free of charge. Please help us to continue our strong educational programming by answering the evaluation questions and post-test questions that will be sent via email shortly after this program ends, so that we can demonstrate our impact to our funding partners. For participants of this webinar who are interested in receiving continuing education credits, instructions for applying for credit will be emailed to you shortly after this webinar has been completed. Next slide, please. At this time, we will proceed with the question and answer part of our program. As a reminder, participants may post their questions via the chat box in the GoToWebinar control panel on the right-hand side of your screen, and the questions will be answered in the order they are received. We have one question here. The first question is, how have the results of the woman trial affected management of von Willebrand patients? Are they all receiving tranexamic acid prophylactically, regardless of the degree of correction?
So I think I'll take that question. Our trial is just getting up and running. We're working with the data center to finalize all of the report forms and submitting a final protocol to FDA for DSMB review. Once that is completed, we will begin enrollment, we hope, in early 2018. In the trial, we will not be using tranexamic acid at the same time as the recombinant von Willebrand factor. It's a randomized crossover trial, so you will either use recombinant von Willebrand factor first, followed in your first 2 cycles, followed by tranexamic acid in your cycle 3 and 4, or you'll be randomized to starting with tranexamic acid in cycle 1 and 2, and then follow crossover to recombinant von Willebrand factor in cycle 3 and 4. We hope by that approach, each woman will serve as her own control, and that helps us to power down, to maintain excellent statistical power while using only 60 patients, which is very helpful in a rare disease. I hope I've answered the question.
I think, Maggie, she might have been, the query might have been specifically about the recently published trial with the acronym WOMAN, which was a randomized trial of tranexamic acid for secondary prevention of postpartum hemorrhage.
Oh, please go ahead. Yeah.
So it was 1 gram for after, if a woman, it was a multinational study, and they enrolled 20,000 women, I think. They were randomized to receive, at the time of postpartum hemorrhage, to standard therapy or a gram of tranexamic acid, or actually they were randomized to placebo versus tranexamic acid, and then they were allowed to repeat it. The providers were allowed to repeat it if there was suboptimal response. And the good news was that in this study, there was reduced, fewer deaths from hemorrhage in the group that received tranexamic acid rather than placebo. So I think that and then there are other trials in the works for using it prophylactically at the time of cesarean. The Maternal Fetal Medicine Units Network is embarking on they haven't started enrolling yet, but they're embarking on a randomized trial of tranexamic acid to prevent postpartum hemorrhage at the time of cesarean delivery. But the question about how the trial has changed our practice, I think that if anything, it has made us that much more cognizant of the utility of tranexamic acid in potentially preventing or treating postpartum hemorrhage. And I think that in the study the prospective study of women with von Willebrand disease that Maggie and I participated in, that we've alluded to several times, none of the subjects in that study got tranexamic acid, yet now we have, and it wasn't readily available on our labor and delivery unit, and we didn't think about it, but now it's part of our massive transfusion protocol. That's even before the results of the woman trial. But I think what the woman trial has shown us is that in those doses of 1 or 2 grams at the time of hemorrhage, it is safe, and that we can use it not only in our women with bleeding disorders, but other women as well. So I hope that augments Maggie's response.
Thank you.
Excellent. Another question that we have, is there a relationship between heavy menstrual bleeding and postpartum hemorrhage? Can we predict postpartum hemorrhage?
So I was just reviewing a case that is going to be presented at our institution for review on Wednesday of a massive postpartum hemorrhage. And the woman had no risk factors whatsoever. So one might think that there would be a relationship between heavy menstrual bleeding and postpartum hemorrhage, but we haven't found it, except in women who have severe underlying bleeding disorders or have significant von Willebrand factor deficiency. If we just look at women with postpartum hemorrhage and screen them for underlying bleeding disorders, we don't find any more underlying bleeding disorders than we do in the general population, which is interesting. Whereas if we screen women who have heavy menstrual bleeding, we find that between 5 and 25% have an underlying bleeding disorder. So except for the severe bleeding disorders and the significant von Willebrand factor deficiency that contribute to hemorrhage, we don't see underlying bleeding disorder being a significant risk factor on a population basis, and we can't predict who is going to have postpartum hemorrhage, and we still have to be prepared that any single woman will have postpartum hemorrhage, whether she has an underlying bleeding disorder or not. There are some conditions that do predict postpartum hemorrhage, like abnormalities of the placenta, where the placenta grows into the uterus, like placenta accreta, women who have twins, triplets, or quadruplets, women at the extremes of reproductive age, women who are getting drugs that might impair the contractility of the uterus, women who have gotten general anesthesia, women who have gotten magnesium sulfate. But the underlying bleeding disorders have not been a huge contributor. And among women who have underlying bleeding disorders, we can't necessarily predict which ones are going to have a hemorrhage or not unless they have extreme levels.
Thank you. The next question is, if blood volume and VWF increase, decrease during pregnancy respectively, then why dose recombinant von Willebrand factor at 80 units per dose? Why not 70?
If you calculate it, it's between 70 and 80. And quite frankly, I consider, as a non-gynecologist, delivery to be a surgical procedure for which in von Willebrand disease, I usually use a dose of 80 units per kilogram. So it was discussed by the steering committee on the protocol. Certainly, it's not clear what dose is exact or will work. It made sense to try a dose. I believe if you calculate it, it would be closer to 75 units per kilogram, but we went ahead, since it was easier to calculate, just to use an 80 unit per kilogram dose, very similar to the dose that's used at the time of surgery.
Excellent. Thank you. This next question is there a set baseline von Willebrand level for inclusion in either of the studies with recombinant von Willebrand factor, or is inclusion simply based on having been diagnosed with type 1 or type 2 von Willebrands?
Okay, so it's solely based on type von Willebrand diagnosis. It is not based on your level today, which we know can be very variable. But if you have had a level below 0.5, you qualify to be in either study.
Excellent. This question is asking, has anyone looked at the cost comparison to using recombinant von Willebrand factor product for heavy menstrual bleeding versus tranexamic acid? And will this be looked at with the study?
I'm excited that whoever asked that question did so. No, I am being very honest. I think that if you're going to prove that this is a superior drug, it has to be cost effective. And in fact, we are going to do a cost effective analysis as part of our assessment of this drug. We want to balance its cost with days of work, school lost, emergency visits, use of having a transfusion or any other intervention. So I think that question is excellent, and I think we need to know that answer.
Excellent. Next question is asking if one of you could speak about the use of Ddavp in pregnancy.
So the problem with Ddavp at the time of delivery is that women are receiving large amounts of fluids and have large endogenous fluid shifts that make the possibility of fluid retention increased and the chance of hyponatremia with possible seizures greater. So it's in our study where we looked at the treatment of women with von Willebrand disease, we had 15 women who were treated in 17 pregnancies, and in only one pregnancy was Ddavp used at the time of delivery. Likely it's not used, its use is shunned because of the risks involved, although during pregnancy itself, we think it's relatively safe if it were used for a procedure where women were also not receiving considerable IV fluids, although we had a patient here who got it for an egg retrieval, got hyponatremic, wound up in the medical intensive care unit. Also maybe postpartum, when women are also receiving fluids and their shifts have changed and they need something to reduce bleeding, it might be able to be used then. But around the time of childbirth per se, it may be a little risky.
Okay. And this is our last question. This will be for Dr. Ragni. A participant is asking, who should participants contact if they'd like more information about the study?
Okay, so there are two different studies, but rather than give you multiple coordinators' names, Ragni at pitt.edu. Thank you. And we encourage you to become involved. Thank you.
Thank you. For those of you who asked questions and they were not answered during this time, we will send them to our faculty and then send those questions and answers to the entire participant list. So you will get them answered. So at this time, I'd like to conclude our question and answer period. You will be able to review this webinar for your reference or share today's proceedings with your colleagues by visiting our website, fwgbd.org, and accessing this webinar under the archived webinars section. We would also like to thank our sponsor, Shire, who provided educational support for this program. For those who may have questions on this material following the webinar, we do encourage you to visit our Ask the Experts feature on our website and submit your questions online. Thank you again for your attendance and participation today, and we look forward to your return for future Foundation webinars. Thank you.
Thank you.